Hello, can you hear me?
Yes.
So we will start soon. Right, so let's start now. And the screen is also visible to everyone, right?
Yes.
Okay, so if there is anyone waiting in the gallery, please admit them. Right. So this is the first case. Um, this is a 56-year-old man referred by GP because of persistently high white cell count, and he has eczema as well. This is power 10 for you guys. And now we will go to power 50 for this patient. Yeah, this is power 50, and let's see the cells. Right. So I would like you guys to report this blood film, please. Anyone who want to make a start. Evelyn, you are the first on the list?
Sure, I'll give it a try. So there is an increased population of atypical lymphoid cells. These are moderate in size with
Mhm.
irregular nuclear outlined clump chromatin and some with prominent nucleoli. The
Mhm.
cytoplasm is basophilic with no granules seen. The red cells are mostly nomochromic nomocytic. I can appreciate many with Howard Jolly bodies. Platelets are largely unremarkable. My impression for this case would be someone with a lymphoproliferative disorder, likely Sezary syndrome, in view of his clinical history.
So what does the clinical history tell you?
So he has eczema, so I'm thinking something with skin infiltration.
Mhm.
And the irregular nuclear outlines are highly suggestive of a cutaneous T cell lymphoma.
Yeah, so this is also one of the trick in exam as well, that you can figure out from the scenario that what you are dealing with. They mentioned to you that this patient has leukocytosis, and eczema as well. Okay. But it is not always the case. It may be a simple leukocytosis as well in the exam. But if they give you a hint, it is very helpful. Yeah, so these nuclear features that this patient has is clumped in a cerebriform way. They are suggestive of a lymphoproliferative disorder, likely Sezary. So, can you complete your report, please?
So I would suggest to send peripheral blood for flow cytometry
Mhm.
for further staging workup um, with a PET CT if they are lymph adenopathy, and to arrange for a bone marrow aspiration and trifine for aspirate for aspirate and cytogenetic and trifine biopsy.
Okay. All right. So you have commented on the cell line, your impression, and your suggestion as well. And next question would be, what is the expected flow in this patient?
So it would be someone with a T cell lineage. So it will be positive for CD3, CD, CD4. I'm not too sure about CD8. I'm not too sure.
Yeah. So before we go ahead, so this is the typical cells of Sezary. I think you cannot find a better cell than this one. I will make it a big for you. It has typical brain appearance. So you cannot find a better cell than this in your practice. This is a not an eco slide. This is a patient slide. Um, but these are the typical features of Sézary syndrome. The blood film features. Yes. So they. What about the flow cytometry? What were you saying?
So I will do T cell lineage flow. So CD3, CD4, CD5, CD7, CD8.
Mm-hmm. They are CD4 positive or CD4 negative,
I think they're CD4 positive.
and
I can't
CD8.
remember. I think it's CD8 negative.
They are CD8 negative, CD7 negative, 26 negative. and they will have T cell clonality as well. How would you treat this case? Or how do you treat Sézary syndrome in general? This will be your third case in the exam.
So treatment of Sézary syndrome, first we have to stage the patient.
Mhm.
And treatment, in this case with blood involvement, likely the marrow is also involved, so he would probably need systemic treatment, which is CHOP-based.
Mhm. He has skin involvement, eczema, so topical treatment in the form of steroids, then systemic chemotherapy because blood is involved and bone marrow is involved, then it will be CHOP-based chemotherapy. If they are refractory to that, then we have ECP, extracorporeal photopheresis. There is no typical BSH guidelines for Sézary syndrome. Um, the one that we study is all from ASH, where they include some advanced chemotherapy for cesarean. But we usually use CHOP-based therapy for systemic and corticosteroids, topical therapy as corticosteroids. And next line is photopheresis. Right. So this is your Sézary case. These are the basic questions that they ask you in the exam. If you have appeared in the exam before, you should continue practicing um, morphology because morphology will be different in your next exam. This is the next case. This is a one day old baby whose blood film has come through to us. His hemoglobin is 77. White cell count is normal. Platelet count is 400. This is power 10 for you. In exam, they can give you Kleihauer blood film as well. They can give you neonate blood film as well. With increasing number of candidates, obviously they will increase the um, level of exam as well. They will make the exam more hard. They will bring new things for you. So be ready for such type of scenarios in the exam. This is power 50. Yes, so Rekha is next on the list. Rekha, what do you think? How would you report this blood film if you were sitting in an exam? Okay, then Habib is next on the list. Shabana Bhatt.
Assalamualaikum, sir. Um,
Salam.
yeah. So
How
blood
would you
film
report
shows,
this? Okay.
yes. Uh, so it's seems RBC morphology is an isopoikilocytosis with macrocytosis, polychromasia, hemolytic picture, and there is an RBCs I have seen and fragmented RBCs, whole jolly body I have seen, few target cells. Um, Otherwise, platelet counts are normal, and WBC is also looking normal in morphology. So, yes, NRBC I mentioned already. And so it's looking like hemolytic anemia. So we need the history of the baby. Uh,
What history do you want? He is 1 day old.
from the
He's born
parents, then
yesterday.
means the patient has means my impression is most likely HDN, maybe because it's newborn baby and hemolytic disease, and the patient has anemia, severe anemia, and there is hemolytic picture. So it's looking like hemolytic disease of newborn.
To
So I
complete
will do
your
the
report,
yes. So I
complete
will
your
do
report.
further testing for the full blood count already done. So I will do the DAT and bilirubin um, and all hemolytic workup with group and screen. So I will go for the urgent maybe for the neonatologist review for to start for the exchange transfusion or top up transfusion accordingly.
Okay, so you have commented on the red cell line because red cell line is affected. You have noticed white cell as well, but you didn't mention white cells in your report. What about the platelets?
I mentioned the white blood cells are normal in number and morphology, and platelets are adequate. I reported already.
Mhm. There were few rectal lymphocytes. This is
Uh,
a band form.
yes,
There were few whole jolly bodies as well.
yeah, whole jolly bodies also I mentioned.
Yeah. This is a reactive one as well.
Reactive, okay.
So you cannot say that on the blood film report that this is HDFN. You need a
Okay,
history for that. Okay. You can say that
yeah,
this is hemolytic anemia, most likely consistent with hemolytic anemia. Please send
yes.
the hemolytic screen. Okay.
Mm,
So you
yeah,
have to mention all the names of the hemolytic screen component in this case.
okay.
Okay. And that I will inform the neonatologist urgent. You are the hematologist. This film is abnormal. So in practice, you call the neonatologist that I have a blood film of one of your patient. These are the parameters. Okay. Please act urgently because you are adult hematologist. You do not deal with neonates. Neonates have their own pediatric hematologist. So yes, this is a picture of hemolytic anemia, and the history of the baby is that the mom has antibodies, and he has now developed hemolytic disease of newborn.
ऐसा बोलो यार, क्यों क्यों कर रहे हो?
Can you please mute yourselves, please? Can you name few antibodies implicated in HDFN?
Yes, the most common is anti-D, and then anti-small c, and mm, K. Cal is the most is causing the anemia. K is the most
Oh,
notorious. Yes, is the most clinical significant. All these three, others also can cause, but it's the less significant.
and the third question would be, how is HDFN usually treated?
So HDFN is exchange transfusion. They can go for phototherapy, um, mostly, or top up transfusion according maybe. So these are the
In a
three options.
sequence, in a
Yeah,
sequence, you jump to exchange
exchange.
transfusion, then you come to phototherapy, then you went to
Yes.
top up. So be in a sequence: mild, moderate, and
Yes.
severe. Mild
Okay.
will need observation. Moderate will
Okay.
need top up transfusions and phototherapy, and severe one, yes, they would need exchange transfusion.
Okay.
Yes, it can be ABO related. It depends on the history, which will be known to the neonatologist. We do not have much information whether it can be ABO mismatch related hemolysis or. Yes. So this is a third case. Again, a 50-year-old patient referred to you by GP, and this is power 10. He was referred to you because of the leukocytosis. And this is his blood film. His white cell count is 132. His hemoglobin is 90, and platelet count is 90 as well. His only complaint is fatigue. This
Sorry, what's
is
the age?
56. All right. So this is power 10, and now power 50. You will not expect such film in exam, because exam findings are not that obvious as it is in this patient. This is a patient blood film, not from Nicholas. Yes. Denusia is next on the list. Sabrina Habib. Mubashir Yamin.
Assalamu alaikum. Yes.
Yes. Awesome. Can you report this blood thin, please?
From RBC point of view, it looks normocytic normochromic mainly, and thrombocytopenia platelet looks decreased. From WBC's point of view, there are abnormal blast-like cells, mostly looking mature lymphoid cells sometime with mature clumped nucleus, but cytoplasmic blebs, all of mostly showing blebbing of now on higher magnification, some of them are indentation, nuclear indentation, showing with cytoplasmic blebs. Smear cells also can be seen.
What is your impression?
Further testing needs immunohistochemistry, flow cytometry to confirm
Yes,
the
this is
diagnosis. It's acute
this is your
leukemia, lymphoproliferative to differentiate in between these two entities.
okay. Right. So you have commented on the white cell count first because they are abnormal.
Right.
Then you
Yes,
have then you yes
yes,
then you have
high leukocyte count, leukocytosis showing mostly abnormal cells.
then you have commented on red cells. Then you have commented on platelets because we comment on the abnormal cell line first. Red cell, white cell is affected, which is the prominent one here. So you have commented on white cell first. You mentioned
Okay.
there are blebs, there are lymphocytes with prominent nucleoli, smear cells, and then your impression was lymphoproliferative disorder. And then you mentioned that this patient would need peripheral blood sending for urgent flow cytometry in this patient. And because he is anemic as well, thrombocytopenic as well, he would need a bone marrow biopsy as well to confirm. Okay,
Yes,
this is your report, which is good. What is the expected flow in this patient? Which lineage will be positive in this patient? T cells or B cell? What do you think?
Oh, B cell.
Why would it would be B cell?
Follicular, no, not for. This is blabbing actually. I couldn't recall the flow or typical morphology of which type of
Sir,
non-Hodgkin.
sir, can I maybe, sir, can I add?
Mm-hmm.
Sir, what I remember is cytoplasmic blabbing with lymphoproliferative disorder is most likely coming with TPLL. But in the scenario, I think scenario you mentioned any effusions or anything, I don't know. I'm not sure.
It does not mean that if the patient has TPLL, he will have effusions as well. But yes,
Okay.
ascites, pleural effusions, they are part of the disease process. Effusion, ascites, they can come with any lymphoproliferative disorder. You will have
Okay.
seen a lot of follicular patients with pleural effusion, a lot of marginal zone lymphoma patient with pleural effusion or ascites. Um,
Yes.
yeah,
So we will go for the T panels and then.
yeah. So T panel will be positive, CD7 will be very positive here.
Yes, CD7, CD2, 3, 5 can be positive. And CD52, I will see for the treatment point of view.
Yeah. How will you treat this patient?
So again, sir, I will answer or Dr. Mubashir will.
Mubashir is the priority because this is his case.
Okay.
Has
He has passed the question to you guys.
Okay. So I will go for the. I mean, it's if symptomatic patient, a patient is already when I mean, is WBC very high, hemoglobin and platelet low, so it's cytopenia. So I will treat as yeah, we can treat as if CD52 positive alemtuzumab, and we can see the fitness of the patient, and we can go for the transplant in first remission.
How to bring down the white cell count low?
Yes. So in that case, we can go for the leukophoresis in urgent. Yes.
He will not need
Leukophoresis.
leukophoresis because there is no
No.
leukostatic effect in this patient. He has no
Okay.
headache. He has no
So,
blur vision or
can we wait for that patient, Dr. Amir, because he is not symptomatic. So,
he,
is that good to
he
wait
has
for symptoms?
he has fatigue.
Okay,
He
okay.
has ongoing
Sorry, I
tiredness.
missed it.
His,
Okay, so
his
he is
count
with
is
these
very high.
symptoms. Okay.
His count is very high. He's
Mhm.
anemic. He's thrombocytopenic as well. Um, Alemtuzumab may take few days to prepare. You may be waiting for MDT as well or bone marrow biopsy result as well. You cannot start it today or tomorrow, alemtuzumab. It may take few days. But how would you bring down the counts?
Steroids. We can
I
give that steroid.
yeah,
Trial of steroids, but in
Yes.
for some reasons, TPLL patients usually do not respond to steroids. Um, we give them a trial only because we have many TPLL patients, but we give them steroids, but counts does not.
Cytoreductive therapy?
Cytoreductive therapy, do you think it will affect the lymphoid lineage?
Mhm.
It affects the myeloid lineage only.
Mm.
Like if the
Mm.
myeloid lineage cells are high, then cytoreduction would work. It does not work on the lymphoid. Um, so yes, a trial of steroids you can use here, but the response rate to steroid is not that good. Yes, the treatment is alemtuzumab, maximum 18 cycles of alemtuzumab to the patient and transplant in first remission. This this one is a 60-year-old patient with progressive anemia and abdominal discomfort, refer to you by GP, because GP is the primary person here in UK healthcare system. The blood films are referred by GP. Sorry, patients are referred by GP to the specialties. This is power 20, and this is yes. So, what do you think is going on in this blood film? Anyone? Anyone can shout out.
It looks a smear of pancytopenia, progressive. Mostly RBCs are actually dimorphic pictures, some RBC fragmentations, macrocytes, teardrop cells also there, maybe some polychromatic cells also are also there in RBCs. Looks like that, but at 20 I couldn't appreciate much. May need to go on 100 resolution. There is also thrombocytopenia, and white cells are also low. Only I can appreciate one white cell that was I couldn't appreciate its normal or abnormal with lineage. That was actually there was one erythroid nucleated red cell also seen.
Okay.
Is there any ultrasound or any other?
No ultrasound.
So this is a hypersegmented neutrophil. Some prominent granulations also.
Hmm. What is your impression?
Maybe simple megaloblastic anemia, the nutritional anemia, or we need to work up for maybe bone marrow if needed to rule out myelofibrosis.
Okay.
Even this hypersegmentation can be due to dysplasia, MDS, we have to rule out also. Myelodysplastic. Starting from nutritional, better to go with the workup for myeloblastic anemia. Then further reticulocyte count also we should send or look for. Is there any hemolysis or anything? Reticulocytopenia will lead to nutritional deficiency or myelodysplasia. For a long time, actually, I'm out of these sessions and teaching sessions. That's why maybe I'm some not coherent or organized, but I'm trying, inshallah. This
Is that
is.
hairy?
Can we go on 100 for this cell? Large granular lymphoid cell maybe, or abnormal myelocyte can be even. Dysplasia showing.
Mm-hmm.
This is same cell or
Yes,
other?
same. This
Same.
is same cell. Yeah, I went back to 50.
Yes, yes. It's help cell fragmentation.
Mhm.
Large thrombocyte, platelet.
Yeah. If you are talking about nutritional, what do you think about nutritional? B12, iron,
B,
folate,
B12 folate. No, B12 folate most probably.
but there are
Others?
electrocytes,
There are leptocytes also,
electrocyte,
cells also.
there are teardrops as well.
Yes.
And this patient has abdominal discomfort as well. So
Male
Sir,
absorption. Male
sir,
do not
sir,
abdominal.
assume,
can
What is? Mhm.
do not assume in reporting or for exam purpose that the patient may have abdominal, a patient may have malabsorption.
sir,
Hmm.
can I add?
Mm-hmm.
Sir, I'm agree with Dr. Mubashir for all reporting. He mentioned everything in WBC, RBC, and platelet morphology. He well described pancytopenia with all findings. My impression is, according to the history, is 60-year and he has abdominal discomfort and progressive anemia, and now teardrop in the blood film and NRBC leukoerythroblastic picture like myeloid one I have seen, and so it's most likely going for MPN is myelofibrosis for me. So I will go for further testing like bone marrow, aspirate refined biopsy with reticulin stain, and of course cytogenetic molecular NGS panel.
Okay. He has abdominal discomfort. They cannot tell you in the exam that this patient has splenomegaly. Then it will be very easy for everyone. This patient has pancytopenia and splenomegaly. So it is either CML or it is either hairy cell leukemia or myelofibrosis.
Yes.
And it will be very easy for even the FY1 can pick that up as well, or the clinical scientist can pick that up as well. So they will give you a wake term. This patient has abdominal discomfort and he has anemia. This is the blood film. You have noticed that this patient has pancytopenia with large platelets and abnormal red cell morphology. one nucleated red cell. Up till now, we have seen there are a few dysplastic neutrophil as well, but this film is very pancytopenic, so it's difficult to find them in this film. So likely it's going toward MPN. But to confirm that this is MPN, because you cannot say that this is myelofibrosis on a blood film. Myelofibrosis has its own criteria of diagnosis, which include bone marrow as well, and other investigation, major and minor criteria. So you would suggest all those tests, and I will do bone marrow biopsy in the patient. I will check the LDH in the patient. I will exclude BCR-ABL, and then, as per WHO 2022, if the major and minor criteria are complete, then this patient will be labeled as myelofibrosis.
Yes.
So what is the significance of elliptocytes? There are many elliptocytes along with the teardrops.
So whenever the spleen is big, you can have different morphology of the red cells. When they pass through the splenic
Okay.
pulp,
Okay.
they become teardrop, they become elliptocyte.
That's right.
This patient is transfused. That's why you are seeing double
Dimorphic sign.
morphology or dimorphic morphology in the blood film. All right.
Can I ask, is there macrocytes? Because I can't really seem to appreciate. Because I think one of the differentials given was megaloblastic. Which are the
This one.
macrocytes?
This is the macrocyte. This is the bigger cells.
So
These
that's
are.
part of myelofibrosis, Dr. Amir.
In this patient, later on, we find out that he has folate deficiency as well. That's why he had macrocytosis. That's why there was one cell that the candidate picked up was hypersegmented. That's why there is element of macrocytosis here as well.
Thank you.
So, how would you treat this case? If this is a myelofibrosis, for example, he had a bone marrow biopsy, and then it shows that there is myelofibrosis. He's anemic, he's thrombocytopenic. How would you treat?
Can I go, sir?
Yes.
Sir, because it seems a high risk patient is has pancytopenia with symptoms. So I will first check the transplant eligible or not eligible. If it is eligible, I will go for the JAK2 inhibitor. Once patient will get the maximum response, then we can go for the allograft. And if the patient is not fit, then we can continue the JAK2 inhibitors. And if it is not responding, at least I think 3 months, we can continue. If it is no response, then we can go for the second line medication or clinical trials. And supportive management, of course, according to the pancytopenia, blood transfusion, and folic acid, like you mentioned, is as folate deficiency, and blood transfusion of the patient if hemoglobin low, platelet transfusion, and prophylactic antibiotics.
Mm-hmm. Do you do the scoring first in this session? Which score do you use for
Yeah.
myelofibrosis?
So dips plus scoring.
Tips 1.
Yeah, dips plus scoring. I
And
will go for it.
yes,
Yeah, and then I will,
And
of course,
according
risk
to that,
assessment
we'll
and then
decide the
fitness.
therapy.
Yes. Yes.
find out whether he is low risk, intermediate risk, or high risk.
Yes.
We check the EPO level in this patient, hematinics in this patient. Our patient was folic acid deficient, so we give him folic acid. We offer him EPO as well because he was in the low risk. But if he is a intermediate risk or high risk, you can offer him treatment in the case in form of JAK inhibitor first and then transplant, or directly in the form of transplant if he is high risk and donor is available. Which JAK inhibitor would you use here?
Ruxolitinib.
Can you use any other one as a first line?
Momelotinib.
Okay. Is there any other one?
There is a trial of pirtobrutinib, and fedratinib is not using now because of the Wernicke encephalopathy.
It's pacritinib. Pirtobrutinib is something else which is used in trial form in CLL in Waldenstone. It's a different medication, pirtobrutinib. It is
Yes, okay.
pacritinib. Pacritinib is
Fedratinib,
used.
yes.
Yeah, it's a nice approved.
It is not approved here in UK yet, but it is in trial.
Fedratinib is a nice approved, I think 2024.
Yes, but now it is less used because of the
Wernicke's
leukoen-
encephalopathy.
leukoencephalopathy, and now because the um, that one is available now. Momelotinib is available. That's why.
The new one is
Sorry,
the
Dr.
pacritinib.
New one is what?
Yes. Yeah, pacritinib
Yes, pacritinib is not BSH, NICE approved yet.
approved.
It's
Yeah.
FDA approved, but not yet NICE approved. Hopefully by next year it will be there.
Sorry, so in the UK, because I don't work here, so you can choose either ruxolitinib or momelotinib as first line, or do you need to fail rux before moving on to momelotinib?
No, momelotinib can be used as a first line.
Okay,
Yeah.
thank you.
Any JAK inhibitor can be used as a first line. No. There's another 60-year-old patient referred by GP to you because of leukocytosis. He has a background of psoriatic arthritis. This is power 10. Power 50 now. All right. So what do you expect in this patient?
Is the Can I go further? Hello.
Yes, go on.
So these are mostly the normocytic normochromic views show the hypochromia in the RBC. And in terms of the WBC, there are the few lymphocytes that are mature lymphos with the medium to large size cell with the high density ratio and abundant cytoplasm with the granules inside.
Mm-hmm.
So, and the platelet morphology is, and the count is fine. Neutros are present. My impression is the lymphoproliferative disorders, most likely large granular lymphocytosis, LGL, TLGL, use my cell seen.
What is the hint in this scenario?
Because there is the autoimmune disease along with that, the rheumatoid arthritis the patient is suffering from.
Mm-hmm. Any autoimmune
So,
disease in the patient with they would have given you full blood count, it would show neutropenia,
so another
and
hint is the neutropenia as well.
these cells are quite a lot in this film, but in the exam film there will be only few cells. You have to look for that. Okay. So yes, likely lymph lymphoproliferative disorder likely LGL, but you need to do further tests to confirm that. What is the expected flow in this patient?
So that will be CD8, I think, positive, and
Mm-hmm.
TCR alpha beta rearrangement will be there. And I think in few cases there will be the delta gamma TCR rearrangement as well, but I'm not sure.
Alpha beta.
So it's not the delta gamma, okay.
Mm-hmm. Okay. So, and the treatment wise,
So patient is, you can say that the patient is showing the neutropenia. So it's been, if been there's any complication with in terms of the neutropenia, then we will treat the patient. Otherwise, I think just to increase the count, we can give the patient GCSF for neutropenia. And
yes, if he has no other symptom um, related to LGL or only very low neutrophil count, you can first try GCSF
mm,
in the patient. But if he is not responding to GCSF and he has other symptoms as well, then what are your choices of treatment for
then I'll go for immunosuppressive therapy for that because it's been autoimmunity. And so
lung?
mm, I don't remember, but it's immunosuppressive.
Methotrexate and cyclosporine.
Okay.
Low dose methotrexate
Okay.
or cyclosporine in the patient with or without um, GCSF. These are common short cases that usually appear in every exam in a different form. That was the last case. If you have any question, please ask.
Dr. Amir, when they ask us for flow cytometry results, do we just give the positive ones or must we also write down what is expected to be negative?
The important negative ones as well,
Okay, thank you.
like whether this will be CD4 positive or negative, CD8 positive or negative. Because you have different T cell leukemias, which are some are CD4 positive, CD8 negative, some are CD8 positive, CD4 negative, some are both negative. So they would be interested to know these, the important ones only, not everything. Right. Thank you, everyone. See you next month.